Good morning. My name is Laura Hendricks, and I am a pelvic floor physical therapist in New York. I am so thankful and honored to be here today to talk to you about the pelvic floor. What is the pelvic floor? Where is it? What does it do? And what happens when it's not working perfectly? What kind of symptoms do our patients present with? And what can we do as physical therapists to help these patients with their pelvic floor dysfunctions? Next slide. So what is the pelvic floor? Well, according to the American Physical Therapy Association section on women's health, the pelvic floor is all visceral, neurovascular, and myofascial structures contained in the bony pelvis from the pubis to the coccyx and between the lateral ischial walls. Next slide. And what are the functions of the pelvic floor? They have many functions. First is a supportive function. So the pelvic floor supports our pelvic organs, like our colon, our bladder, our uterus, our prostate. It also helps to support a baby in our pregnant patients. The pelvic floor also has a sphincteric function. We're going to learn that the pelvic floor has 3 different layers, and in layer 2, we have our sphincteric muscles. Those help us to keep us dry. So the sphincters will close when we don't want to urinate and when we don't want to have a bowel movement. When we're not ready for that yet, the sphincters will close. When we are ready, the sphincters will open. The pelvic floor also has a sexual function. Some of the muscles in the pelvic floor are helpful in arousal and also to achieve orgasm. The pelvic floor muscles also are big stabilizers. So our pelvis is always kind of shifting. Sometimes we lose weight, sometimes we gain weight, sometimes we have a baby in our belly, and so our pelvis is changing. Those pelvic floor muscles help to stabilize our bony pelvis. And the pelvic floor also helps with lymphatic drainage, so there is also a sump pump nature to the pelvic floor muscles. Next slide. So we're going to talk about the pelvic floor anatomy and really kind of figure out where these muscles are. Next slide. So when we talk about where is the pelvic floor, we talk about 4 bony landmarks. The first one is the pubic symphysis. The second one is the coccyx. And then the third and the fourth bony landmark are our ischial tuberosities. So we're going to go ahead and switch the screen so you can see me a little bit bigger. And I have my pelvic model right here. Betsy, can you see me a little bit bigger? Okay, so here is our pelvic bones right here. And when we look at the front of the pelvis, we see the pubic symphysis. That's bony landmark number 1, right where the 2 pelvic bones come together. Bony landmark number 1, pubic symphysis. And I want you to appreciate all the muscles here that are attached to the pubic symphysis. We're going to learn in a second, these are some of the pelvic floor muscles. Look how many are attached at bony landmark number 1. Also attached here, if you can appreciate, is our abdominal wall. So our abdominal muscles also play a part in what happens to our pelvic floor. Another big muscle that attaches right here at bony landmark number 1 is our adductors, which are often involved whenever we see pelvic floor dysfunction. Typically, our adductors are also involved. So again, pubic symphysis, bony landmark number 1. If we turn the pelvis around, we'll notice the tailbone and the coccyx bone. This is bony landmark number 2. And I want you to appreciate all the muscles. Again, these are part of our pelvic floor muscles we're going to learn in a second, but look at how many muscles are attached at bony landmark number 2. If I hold the pelvis up, we're going to see ischial tuberosities on either side, bony landmarks 3 and 4. And I want you to appreciate again how many muscles are attached to bony landmarks 3 and 4. Also attached here are our hamstring muscles. So we always want to make sure we're checking hamstring length, which we'll get to later. Now, if we turn the pelvic model around and move it this way, we see the vaginal opening, the anal opening, and we revisit those 4 bony landmarks. the pubic symphysis, ischial tuberosity, the coccyx, the ischial tuberosity, and back up to the pubic symphysis, and we draw a line to each one of these bony landmarks just like this. It makes almost a diamond shape. Everything in this diamond shape is pelvic floor muscles. So you can see our pelvic floor lives right here, right underneath our pelvis, and it forms a hammock or a sling, just like this. And where my hand is would represent the most superficial layer of the pelvic floor. There's 3 layers. So there's a layer here, the superficial layer. There's one more deeper, the second layer, and one more deeper still. So 3 layers of muscle form the pelvic floor muscles underneath the pelvis, just like this. And just like we said, they have lots of important functions. So if you can imagine, again, if we go back to that support function, these little layers of muscles are helping to support the uterus, the bladder, the prostate, the colon, a baby, right? So big, big job. So they have to have enough tension to be able to hold up all those organs. They also need to have enough length. We want to have nice excursion in these pelvic floor muscles. The length will help us with urinating when we want to urinate, having a bowel movement when we want to have a bowel movement, help with delivering a baby, and also will help with sexual functions. So we want to have nice length. So here's a nice representation of our anatomy of the pelvic floor muscles. Next slide. Here we go into a little bit of the different layers of the pelvic floor muscle. That most superficial layer, we have the bulbocavernosus in a female and the bulbospongiosus in a male. We also have the ischiocavernosus. And also in layer 1, we have the superficial transverse perineum. This is the perineal area between the vaginal opening and the anal opening. This is usually where we'll see our episiotomies, which we'll talk about in a little bit. If you can imagine, with an episiotomy, we have a little cut or a little bit of a tear there in that superficial transverse perineum. And if we don't make sure that during healing of the episiotomy, we have nice mobility in that muscle, sometimes it can scar down and bound down, decreasing mobility, causing pain in the future. Layer 2 is our sphincteric layer. So that's where we see the compressor urethra, the sphincter urethra, and then the deep transverse perineum, the muscle below the superficial one. So that's the layer of muscles where we see our sphincteric function, where we're holding in the urine. We want to have that nice sphincter closed when we don't want to urinate, and then when we relax the pelvic floor, those muscles will lengthen and open and allow us to void successfully. Layer 3 of the pelvic floor is where we see what people sometimes call the levator ani. We see the pubococcygeus muscle, the iliococcygeus, the coccygeus, and the puborectalis. And if you look at the names, they suggest where these muscles start and where they insert. So that's a little helpful. Sometimes they're referred to as the levator ani, and sometimes we hear our patients have levator ani syndrome. Usually that means that layer 3 has a little bit of spasm or is hypertonic. So those are the muscles that are in each one of those layers that we mentioned before. Next slide. So here's a nice little representation. The picture on the top is showing us looking down into the pelvic floor. You can see the coccyx, you can see the ischial tuberosities, you can also see the pubic symphysis, and it kind of gives you a nice view of that hammock or sling that I spoke of. And those muscles are very, very important, have a huge job. You can imagine all the pelvic organs on top of them, and they need to have enough tension to hold those pelvic organs up. The lower picture is now showing a patient on their stomach. Again, find the coccyx, the pubic symphysis, and the 2 ischial tuberosities, and you can see that nice sling or hammock of the pelvic floor muscles right there. Next slide. So there's also two muscles that are kind of accessory muscles to our pelvic floor. Let me move the picture over a little bit. And those are the piriformis and the obturator internus. Both of them are external rotators of the hip, and they really work together with the pelvic floor. If you can appreciate that piriformis muscle, let me see if I can get my face over a little bit so you can see a little bit better. If you can appreciate where the piriformis muscle is, you can see that the sciatic nerve is running right below it. So very often when we hear patients having sciatic pain, we want to make sure that that piriformis has nice length to it and there's not too much tension pushing down on the sciatic nerve. Also, the obturator internus, which lives a little bit below the piriformis, it also has an association with both the sciatic nerve and the pudendal nerve. So whenever we have pudendal pain, levator ani syndrome, that deep layer 3 of the pelvic floor muscles, there could be some sciatic involvement or some pudendal nerve involvement. What's interesting is when we do an internal vaginal exam to assess the muscle strength in the pelvic floor, if we go deep to layer 3, we can feel the obturator internus when we know we're on it because we have our patients resist external rotation and we feel the muscle pop out. So very often people that have deep hip pain, sometimes we see this with gymnasts or dancers, their obturator internus is involved and can be spasmed, and we can get to that muscle internally, vaginally, and help reduce some of the spasm in there. So we always want to think about the piriformis and the obturator internus when we're working with pelvic floor muscles. Next slide. So what happens when things change with these muscles? Just like any other muscle in our body, our bicep, our upper trap, our lower back, those muscles can spasm or they can be a little bit weak. Or maybe they don't have good coordination of how and when to contract and relax. The pelvic floor is no different. So we can see pelvic floor dysfunction in these 3 layers of muscles as well. Next slide. So what happens when we have too much tension in our pelvic floor, or it's spasmed, or we just don't have nice range of motion? Maybe we just don't have that much excursion. But too much tension, typically in the pelvic floor, too much spasm, too much hypertonicity, we see a lot of pelvic pain. We see pain with GYN exams. We see pain with intercourse. We sometimes see pain just putting their clothes on every day, pain with anything like their underwear touching, pain with trying to put a tampon in. That may indicate the patient has too much tone in their pelvic floor. On the contrary, too much mobility or too much length, not enough tension, we can see prolapse or incontinence. Because remember, normal resting tone might be right here. If we have too much tone and it's spasmed, that's pain. We usually see pelvic pain. When we have not enough tone, we usually see incontinence or maybe even prolapse. Maybe a patient having years of constipation, they're pushing, they're bearing down. Sometimes we see too much mobility there and we can see a prolapse as well. Next slide. So here are some examples of a hypertonic versus a hypotonic pelvic floor. So with hypertonicity, too much tone, spasms, maybe we did sports that required us to keep a really tight core. Maybe we always walked around pulling in our tummy, or maybe we just have a high stressful job or a lot of stress in our lives, which who doesn't right now, right? We're living in a pandemic and kind of tricky time. So there's a lot of increased stress for all of us. But that hypertonicity, some of the things we'll see is pelvic pain, vaginismus, vulvodynia, dyspareunia, dysuria, things of that nature. As opposed to a low tone pelvic floor or a hypotonic pelvic floor, that's where we see patients with either urge incontinence, stress incontinence, mixed incontinence, or some of our prolapses. Next slide. So what can we do as physical therapists? How can we work with these patients? What can we do? Next slide. So first of all, what can we treat? We can treat patients with fecal and urinary incontinence, urinary urgency and frequency, dysfunctional voiding, painful urination, painful bowel movements, pelvic pain, abdominal pain, hip pain. We can help patients with prolapse. We can't necessarily fix the prolapse. There's different grades of prolapse, 1 through 4. Grades 1 and 2, we can usually work with those patients to try and prevent the prolapse from progressing. Pelvic organ prolapse grade 3 or 4 sometimes can require surgical intervention, maybe a pessary, we could try that. But again, pelvic floor physical therapy won't 100% correct a prolapse. Can we pull it up and back a little? Maybe, but it's not that we're going to fix it. We just prevent it from getting worse and progressing. We can also help patients after abdominal pelvic surgeries. The big one for us would be C-sections or prostatectomies. We can help patients that are having trouble evacuating their bowels completely. We can help with constipation. We can help during postpartum and pregnancy and any pregnancy-related musculoskeletal issues. And like I just mentioned before, we can help patients after post-prostatectomy because males have pelvic floors too. Next slide. So what are the contraindications and precautions for pelvic floor therapy? This is certainly not a comprehensive list, but this is one that we kind of generally use. We must have a physician's consent. We also must have the patient's consent. We always have to ask the patient if they'd like a chaperone in the room, and we certainly always get their consent when we're going to be doing any sort of pelvic floor work. Patients who just had a baby 6 weeks or less, patients who just had surgery 6 weeks or less, anybody with an active infection, we do not work on pelvic floor at that time. We'll send them to their doctor to go get antibiotics and clear the infection first, and then anybody under 18 without consent. Next slide. So what happens during a pelvic floor physical therapy evaluation? So the first thing that happens is we get to know the patient. It's usually an hour-long physical therapy evaluation because there's a lot to do. There's a lot to talk about. There's a lot of history to take. We want to make sure we establish a rapport with the patients and make them feel comfortable and safe in our care. We want to make sure that they trust us. And we also certainly want to make sure that they know this is their journey and we are there for them and this is a safe zone. And at any time, if they are uncomfortable, we stop the evaluation. As you can imagine, not many people know what physical therapy for the pelvic floor is, but we're trying to change that. So when patients come in the room, they're already a little bit upregulated and nervous and what's going to happen and is she going to look and what's going to happen in here. So we try to de-escalate the patients, make them feel safe, explain to them exactly what we're going to do. And in that hour, for the first 15 minutes or so, we're just talking and we're taking a very detailed history. We're asking, what brings you here? How long has this been going on? What makes it better? What makes it worse? Have you had any treatment for this before? We ask if there's any diagnostic tests being done. Have you had any urodynamic testing, any ultrasounds of your abdominal area, defecography testing for the patients that have had difficulty with incomplete bowel emptying or patients with constipation. We ask who they live with. Do you live alone? What kind of support system do you have? What kind of job do you have? What kind of things are you doing at your job that might get in the way if we have these pelvic floor symptoms? Are we lifting heavy boxes and we have a prolapse? Are we having a pudendal neuralgia and you sit at a computer all day? So we want to know, what is your day like? We also ask patients their gynecologic history. Have you had any pregnancies, any deliveries? Did you have C-sections? We're asking about the abdominal surgeries. Did you have an episiotomy? We're seeing, okay, we're going to check to see how much mobility is in that superficial transverse perineum, or is it scarred down and there's not much mobility, so there's not much excursion, and now that's why this patient is having painful intercourse, perhaps. We ask the patient about a GI history, any urinary history, psychosocial history, histories of pain. We also ask about their urinary function. How often are you going to the bathroom in a day? Do you have difficulty initiating a stream of urine? Does it hurt when you go to the bathroom? Do you feel like you completely empty? We ask about how much water are you drinking? How much caffeine are you drinking? As we know, we'll talk about a little bit later, caffeine is a bladder irritant. And if we're drinking too much caffeine or too much coffee and we're wondering why we're going to the bathroom all the time, maybe that's why. Maybe we're just having too many bladder irritants. We also ask about bowel function. How often are you pooping? What do your poops look like? We have the Bristol stool chart, and then we can ask patients what it looks like, and we can get a sense of, are we drinking enough water, or do we have little pellet poops? Maybe we need to be drinking more water. We ask if patients need to do any splinting when they're having a bowel movement. That might indicate that they have a prolapse. Splinting is when we're pushing up on that perineal region, which would mean we're pushing the prolapse up and away to allow us to have a bowel movement more efficiently. We ask about any abdominal surgeries, any surgical history in general. And we ask about any orthopedic issues in the past. Have we ever fallen on a coccyx bone? We ever injure our coccyx? Maybe that could affect our pelvic floor, right? Because the coccyx is one of our bony landmarks. So we ask a very detailed history. We also have the patient show us how they're walking, and we check their posture. We have them bend forward, we have them side bend, and we're watching to see how is that pelvis moving in all planes. Is there any restrictions? Do we have some restrictions in our low back? Is the pelvis not moving properly? Is the pelvis level? Might we have a little bit of a rotated pelvis, which we can see by looking at the PSIS or having the patient bend forward. We have the patient stand on one leg. So we're checking what is the pelvis doing with all different mobility. We also do an external soft tissue palpation. We're checking to see if there's any tenderness or tone or tension in the abdominals, the psoas. The psoas is a big player in pelvic floor dysfunction. Believe it or not, when males have testicular pain, very often it's just a tight psoas. So we can do hip flexion stretching. We can do soft tissue mobilization to the psoas. So we're checking all the muscles in and around the pelvic floor just to make sure they have nice tone and nice length, and there's no tenderness or tension on those muscles. We also check muscle lengths in the hamstrings, the adductors, the piriformis. Remember, those muscles were all attached to our bony landmarks of the pelvic floor. So we're checking to see, is there tension in those muscles as well? Next slide. Then we check just general range of motion in the low back and in the hips. We're looking for tension. We're looking for weakness. We do special tests. We can do the Faber. We can do the compression tests, a lot of your orthopedic tests that you guys are the best at. And then we do a pelvic floor muscle assessment. First, we're just observing externally. We're looking at the tissues. Do they look clean? Do they look dry? Are they intact? We're making sure there's no redness, irritation, discharge, inflammation. We're just kind of checking a gross look at the pelvic floor muscles. We do external palpation, so that would be really at layer 1. We're checking to see if there's any pain, any sensitivity. And then we ask the patient to contract and relax. Do a Kegel, which is not always the right answer for people, but we do want to see, do they have that excursion? Can they lift? Can they lower? The cue is usually close the anal opening. When we have the patient do that contraction, we're looking to see, can they isolate the contraction, or when they do it, are they kind of tensing up everything, their glutes, their abs, their adductors, their eyebrows, everything they can to kind of lift that pelvic floor, or are they doing a nice isolated contraction where they're just lifting the pelvic floor, which is what we do want. So then we do an internal muscle assessment. We have a gloved finger and we go in layer by layer. So layer 1 is about the first knuckle, layer 2 is the second knuckle, layer 3 is the third knuckle. And we go in very carefully. We're always checking with the patient. Of course, we get consent. We tell the patient it's a safe zone. If they're uncomfortable at any point, we stop. And when we go in vaginally or rectally, wherever we're going, we just gently sweep left and right. If this is the vaginal opening, we come in at about 6 o'clock if we call the pelvis a clock. And then we sweep around the sides, and we're feeling the integrity of those muscles to see, is there tension in there, or is there nice give in there? Do we see any spasm? Do we just see nice tone and it's nice smooth tension in those muscles? So we do internal palpation. We feel around. We never really go to the top. That's where the urethra is, so we stay away from there. And we go layer by layer, assessing the muscle tone, feeling for tension. If the patient has pelvic pain, we do not check to see their strength because we don't want them to contract anymore if they're already hypertonic. So for patients with pelvic pain, we skip this next part. For patients who have really beautiful tone and maybe they're just there for leaking, maybe they have prolapse, those are the patients we want to try to strengthen and increase their tone. So at that point, we would have them contract or close their anal opening, and we would feel the muscle strength of the muscles. And we want to feel both sides because sometimes we have more strength on the right side of the pelvic floor than we do on the left. So we would be feeling, and just like any other manual muscle test, the strength is measured out of a 5. We first have the patient do a contraction. That would give us the muscle strength. Then we want to see if the patient has good endurance. We want to have the patient do some quick flicks. How many repetitions can they do of that maximum contraction that they just did? Can they do 3? Can they do 4? And we're checking how much endurance they have. We also want to see how long they can hold a pelvic floor contraction. So we'll have them lift, hold, and then we start to count 1, 2, 3 to see how long they can hold. And by the way, as we're doing this, when we're checking the strength, we're checking the quick flicks, how quickly they can contract and how many repetitions they can do, and then how long they can hold that maximum contraction for. Here's a place where we would be generating some of our goals, right? On the contrary, for patients with pain, we're feeling how much tenderness do they have? Do they have a +1 tender to palpation at their iliococcygeus or their pubococcygeus on the left? Or do they have a +2 tender to palpation on their obturator internus, which we can get through layer 3 of the pelvic floor? If they have +2 tender to palpation, that might be our goal, to try and decrease that tenderness. So here during our evaluation is when we're starting to formulate some of our goals. Also before, do they have tight adductors? Do they have tight hamstrings? Also thinking about goals here. We also have the patient fill out some functional outcome measures. We like to use the female genitourinary pain index. We also use the colorectal anal distress inventory, the urinary distress inventory, and the pelvic organ prolapse distress inventory. And these are just little questionnaires the patients fill out and they become graded. And then we can measure any progress along the way. When we do a progress note, we have them take those tests over and see hopefully that their scores have improved. Next slide. So now we have done our assessment. We've checked how is their abdominals? I think I talked about that. We want to check any abdominal restrictions. I don't think I said that. But during the evaluation, we also check the integrity of their abdominals. Do they have any restrictions? Have they had any laparoscopic surgeries? Have they had any C-sections? Do they have a history of IBS? Have they any diverticulitis? So sometimes in the abdomen, we may see some restrictions during our assessment of the abdominopelvic fascia. So now we're on to treatment. The first thing that we'll be doing is manual therapy. I usually like to start at the abdominopelvic fascia, and we can do myofascial release. We can do soft tissue massage. We can do the I love you massage to get an increase in motility of the large intestine for our patients that have constipation. Or we can do some myofascial release to our patients who have had a C-section or patients who have laparoscopic prostatectomies. So lots of myofascial work abdominally. I also then do some gentle manual stretching to all the muscles of the pelvic girdle. Might be on the next slide, but we'll talk about it now. Where I stretch the hamstrings, I stretch the adductors, I stretch the piriformis. And by the way, all the while that I'm doing the manual work, either abdominally or while I'm stretching the muscles of the pelvic girdle, I'm having the patient breathe. We're doing diaphragmatic breathing where we're using rib excursion and trying on the inhale to do some pelvic floor lengthening to help increase excursion in our tissues. And the nice deep breathing also helps to downtrain our nervous system. So we also do neuromuscular reeducation. So what does that look like? Well, in a pelvic floor that is hypertonic, for our pain patients, we do a lot of that diaphragmatic breathing where we're trying to increase excursion through our rib cage on the inhale. Also on the inhale, we're trying to lower or lengthen the pelvic floor. So any of those hypertonic tissues, we try and lengthen them during our inhale. We also do contract relax techniques like a progressive relaxation technique, because sometimes with our patients that have hypertonic pelvic floors, they have a very upregulated nervous system. So we need to quiet that down. So one of the progressive relaxation techniques that I like to do is while I have the patient laying down, I start at their feet. And I have them pull their toes up to their nose as hard as they can. Pull, 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 keep going, keep going, keep going. Then they dramatically relax it. And I have them take that nice breath in through their nose with rib excursion. And a long, slow exhale through pursed lips. And then we go on to the knees. I have them push their knees down into the table as hard as they can. Push, 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 push. Have them keep pushing and then let it go. And then again, nice deep breath in through the nose and a long, slow exhale. And as we work up the chain, then I would have them contract their glutes, make a fist, push their elbows down into the table. And one by one, as we go up the chain with that really tight contract and then that relax and that nice inhale and exhale, we can down train the nervous system, get them a little bit quiet and increase the length in those tissues. Also with hypertonic pelvic floor, we would do manual therapy where we would go in vaginally or rectally, depending on our patient, and we would just very gently sweep through the muscles of the pelvic floor. And when we feel areas of tension, we give a little bit of a hold, almost like a trigger point release. We hold and we have the patient do their diaphragmatic breathing. And it's amazing because you can sometimes feel that muscle just give way and melt right underneath you. You can also, if you find an area of tension and you're giving a hold and you're having the patient breathe, you can move their legs back and forth, almost like a windshield wiper, just to get even a little bit more stretch or a little bit more mobility. For our hypotonic patients, we need to increase their strength and their coordination. So we want to go in with those patients from a pelvic floor standpoint. We also go in vaginally or rectally, and we're going to have them do that, close the anal opening and release. But we want to make sure they're isolating those pelvic floor muscles. Again, we don't want them to use their glutes. We don't want them to use their adductors, and we don't want them to use their abdominals. We want them to just isolate that pelvic floor, lift and lower. We also want to make sure that we are working lift and lower, lift and hold to try and get the slow twitch and the fast twitch muscle fibers, and then also repeated lift and lowers. So we do quick flicks, we do elevators where we lift the pelvic floor to the first floor, the second floor, and down. Lift to the first floor, second floor, and down. So a nice controlled contraction. And then we lift, hold, and release. And also very important when we're doing pelvic floor training for strength, not only do we want that nice isolated contraction, but as we're contracting the pelvic floor, we want the patients to exhale. Because if they're holding their breath, they're almost doing a Valsalva and they're bearing down on a pelvic floor that's trying to lift up. So while we lift, hold, we exhale to get rid of the pressures in our canister, if that makes sense. We make sure we get those contractions real well on the table, and then we bring them into more functional activities. So we have the patients engage their pelvic floor and we simulate carrying a laundry basket or carrying a grocery bag or practicing going from sit to stand. All these times where patients that leak really see leaks. So we want to engage the pelvic floor, hold it there, lift up the laundry basket as we exhale and get rid of the pressure out of our canister. Next slide. I talked about doing manual stretch of the pelvic girdle. That's where we want to make sure we're stretching the piriformis, the adductors, the hip flexors, that psoas muscle we talked about, the hamstrings. And in terms of therapeutic exercise, patients with a hypertonic pelvic floor, we want to lengthen those muscles. So I do a lot of yoga posing with these patients. We do child's pose, we do happy baby, we do the butterfly, the cat cow. Maybe you're familiar with some of these yoga poses. If not, look them up because they're great for our patients with pelvic pain. We have them do these poses where we'll lengthen the pelvic floor, and as they're in the poses, we do our nice diaphragmatic breathing to lower the nervous system, lengthen the muscles. Makes sense. And then for our hypotonic patients, those are the ones we need to strengthen those patients. So we're going to be, like I said, we'll be on the mat first, get a nice isolated contraction, do our quick flicks, our endurance ones where we lift and hold, we do our elevators, and then we want to also strengthen the muscles around the pelvic floor to help support even more our transverse abdominis, our adductors, some of our abdominal muscles. So we'll put those patients in positions like quadruped, try some bird dogs with them or some fire hydrants with them. And then we do a lot of real functional activities with them while they're engaging their pelvic floor and breathing. Next slide. And one of the biggest things we can do with our patients is patient education. Teach them what they can do with carryover at home. For our patients with pelvic pain or difficulty with intercourse, we can introduce dilators to them where they can get a small set of dilators. Patients who are afraid to have intercourse, they're afraid of that pain. We can start dilator therapy with them here, where I actually have my dilators right in front of me so I can show you. Intimate Rose is a great company. They have a great website. You can go on their website and see a nice educational video on dilators. But we start the patient with small dilators, and then they kind of go up in size. And the patient that's nervous to have intercourse, as we get them a little bit more comfortable and they're able to tolerate some manual work, they can bring the dilators home, load it up with some lubrication, put it inside and let it live there while they breathe and do their diaphragmatic breathing for 3 minutes. And then they can take it out. And each day that they do that, they get a little bit more used to having something in there that they know is not painful. We can even encourage, if the patient is comfortable with it, getting their partner to come into therapy. I have plenty of times where I have spouses and partners come in and we educate them on how to help their patient get over this little hurdle of pelvic pain by using dilator therapy at home. We can also teach the patients the contract relax like I did with you guys before, and you should try that because it's really great. Where if we can't seem to settle our body, give into the stress, give into the tension, and give it all you got and squeeze, 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 let it go, and then take a nice deep breath in and out. And what it is we're fatiguing the muscles, right? We can teach them meditation, diaphragmatic breathing. We can teach them to keep a bladder diary for the patients that are having episodes of incontinence. What happened during those episodes of incontinence? Did we wait too long to urinate? Or did we have a bladder irritant kind of drink? We can talk about that now. Bladder irritants are things like lemons, limes, caffeine, alcohol, chocolate, unfortunately, spicy foods, tomato sauces. Those are our big ones. So we want to teach the patients to avoid bladder irritants. We also want to teach patients to avoid the jick void. The jick void is, I'm going to go just in case. Our bladder can hold this much urine, let's pretend. And it usually is about typically an hour and a half to 2 hours that we should be able to hold our bladder. But as little kids, we always heard, we're going to the store, I want you to go just in case. Or we're going to grandma's house, I want you to go just in case. We're going on a long car ride, go just in case. Or maybe you have to go to class now and you're going to go just in case. And what happens is when we keep going, when our bladder is only this full because we're going just in case, or we have a patient that's starting to have incontinence and leaking and they don't want that to happen, so they're just going to go when they feel the littlest bit, and you keep kind of going to empty, we start to retrain our brain and our bladder that this much full is when we have to go. So now we've retrained our bladder kind of in a negative way. So what do? Usually these patients are our incontinent patients. So what we try and retrain them to do is to avoid the just in case void, to try and build up the bladder interval. For example, if this is my bladder and this is my pelvic floor, only one of them can contract at a time. So if my bladder is saying, hey, Laura, it's time to go to the bathroom, and my pelvic floor is weak, the bladder is going to win and I'm going to leak. But now that we've learned these pelvic floor contractions and I learn how to close the anal opening and do my quick flick contractions, if my bladder is telling me I have to go and it's only been a half hour, I know that I shouldn't have to go yet. It's too soon of a bladder interval. So the bladder saying, Laura, go. And I'm going to say, I'm going to do a pelvic floor contraction. I'm going to lift and lower, lift and lower, and lift and lower, and give my bladder the signal to just keep filling and ask it to give me 2 more minutes. And sometimes by doing those contractions of the pelvic floor, we can quiet the bladder down and tell it just to keep filling. And little by little, we'll add 2 minutes here, 2 minutes here, until we get up into a better bladder interval and we're not going every half hour or so. So we want to learn how to avoid the just in case void, but it's a process that does not happen overnight. We also teach patients proper toileting posture. Patients who have constipation, we teach them about the squatty potty, where you put your feet up on almost like a step stool, but the squatty potty is a real thing. It's very cool. We all have a little angle in our anorectal area, anorectal angle. And as you sit with your feet up on a step stool, it straightens out that angle, makes it a little bit easier to have a bowel movement. We also teach our patients the importance of a lot of water. Some people that have incontinence say, I'm going to stop drinking water after 7 o'clock so I don't have to have an accident in the middle of the night. But what happens is then you dehydrate yourself and now you have concentrated urine which is a bladder irritant. So the bladder is going to say, I don't want this concentrated urine. I want this out too. So we got to manage our water intake. Even if you take little sips, try not to get ourselves dehydrated. And then we teach home exercise programs. We teach them the stretching and the yoga poses for the hypertonic patients. The hypotonic patients, we teach them functional exercises they can do at home while they're contracting and strengthening their pelvic floor. Next slide. These next two slides are just studies showing the efficacy of the pelvic floor physical therapy program. The first one is looking at a hypertonic pelvic floor. The second one is looking at a hypotonic pelvic floor. And there are so many studies out there showing the efficacy of pelvic floor physical therapy and how we have effectively and successfully helped patients who are either hypertonic or hypotonic, or maybe we have great tone and we just don't have good coordination and we have no idea where the pelvic floor is, and we can help patients with that too. Next slide. This is the second study. It's showing the efficacy of a hypotonic pelvic floor physical therapy treatment and how it is effective and successful. Next slide. So that is it. I hope that this has been helpful, and it was such a pleasure to talk to all of you. If you have any questions, please don't hesitate to reach out. Again, my name is Laura Hendricks. My email is lhendricks1@northwell.edu, and my phone number is right there listed below, 631-806-1901. Betsy, thank you so much for having me. And again, thank you for the day, and please don't hesitate to reach out. Take care of your pelvic floor. Order pelvic floor therapy for everyone. Thank you.